Good afternoon to you all. I will now ask that the live stream is started. Welcome to the meeting of the Health and Wellbeing Board being held on Monday the 11th of March 2024. For those present in the meeting, if the fire alarm sounds, please leave the building by the nearest exit and proceed to the assembly area in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. To ensure that the recording quality is maintained, please speak as clearly as possible, keep background noise to a minimum. Please ensure that mobile phones and other devices are turned to silent. Others are permitted to film, photograph and record our public meetings, providing that it does not disrupt the business of the meeting. If there are any members of the public present who do not wish to be filmed or photographed, please raise your hand now so that any such person filming or photographing may be made aware. Voting will be undertaken by a show of hands in the room. Only committee members present may vote. For participants in the room, please use the microphones to speak, pressing the button on the right of the unit and speak directly into the microphone. We have a number of people in attendance as virtual participants. Can I request that they use the raise hand function within the system if they wish to contribute? Item 1, do we have any apologies for absence?
We've received apologies from Councillor Lester, John Butlin and Dr Mike Hearn.
Thank you. Any name substitutes?
Emma Roberts is acting as a substitute for John Butlin for the Hereford and Worcester Fire and Rescue Service.
Thank you. Before we go on to declarations of interest, just so that those who may be listening or watching on YouTube, can we just go around the room and introduce ourselves and state who we are representing? If I start with you, Henry.
Hi, I'm Henry Merrick-Murgatroyd. I'm a Democratic Services Officer for Herefordshire Council.
Matt.
Sorry, afternoon everybody. Matt Pearce, Director of Public Health, Herefordshire Council, member of the board.
Julia Stevens, Public Health Lead, Herefordshire Council.
Hi everyone, I'm Mohammed Susi, Public Health Programme Officer, Strategy and Partnership at Herefordshire Council.
Kristen Pritchard, Public Health Lead, Herefordshire Council.
Good afternoon, Chair.
Good
Pauline
afternoon.
Crockett, Councillor, Health and Wellbeing Scrutiny Chairperson.
Yeah.
Good afternoon. I'm Frances Martin, Deputy Chair for Wye Valley Trust, here observing this afternoon. Thank you.
Good afternoon. I'm Darryl Freeman, Director of Children's Services.
Good afternoon. I'm Hilary Hall, Corporate Director of Community Wellbeing and the Director of Adult Social Care.
I'm Steve Brewster, the CEO of Active Herefordshire and Worcestershire, but here today is the VCS rep.
Christine Price, Chief Officer of Healthwatch Herefordshire, member of the board.
And David Mahaffey, Exec Director for Strategy, Health Inequalities and Integration at the Integrated Care Board and a member of the board.
And prize for longest title. Jane Ives, Managing Director of Wye Valley Trust and a member of the board.
Councillor Carol Gandy, Cabinet Member for Adults, Health and Wellbeing. And those on the virtual screen, if we could start from the top. Sue.
Yeah, Sue Harris, Director of Strategy and Partnerships, Herefordshire and Worcestershire Health and Care Trust, and I'm a member of the board.
Helen.
Good afternoon, everyone. Superintendent Helen Wayne, Local Policing Commander for Herefordshire.
Hayley.
Hi everyone, I'm Hayley Doyle and I'm Service Director for All Age Commissioning at Herefordshire Council.
I can't read them after that. Adrian.
Hello everybody, I'm Adrian Griffiths and I'm Strategic Finance Manager for Partnerships and Integration for Herefordshire Council.
Who else we got? Marie.
Good afternoon, Marie Gallagher, Transformation Improvement Lead for Herefordshire Council.
Have I introduced her? Emma? Yeah. And is it Agile? Harple.
Yeah, Harple Lodgler, Public Health Consultant, Herefordshire Council.
Ivan.
Hi everybody, Ivan Powell, Cabinet Member for Children's Services from the Council.
Adrian.
Is that Emma?
Eva? That's everyone, isn't it? Yeah. Okay.
Sorry, Emma Roberts, Head of Prevention for the Fire and Rescue Service. I'm representing John Butland today.
All right. Thank you. Thank you. And Kevin. Do we miss you out, Kevin? How could we have missed you out?
Sorry about that, and my apologies for not being in the meeting. Kevin Crompton, Chair of the Adult Safeguarding Board and member of the board, but principally here today to present the report. Councillor, and sadly, I've got to give my apologies for the rest of the meeting. I've had a few personal issues to deal with in the last week with my father-in-law being ill, so but I'll be here to present the report.
Right, I'm sorry about that, but thank you for coming. Thank you. Right, item 3 is declarations of interest. Do any members wish to declare any table A or B or other interests in any agenda item? No declaration stated. Item 4 is the minutes. And the minutes of the meeting held on the 4th of December 2023 are included in the agenda pack at pages 7 to 14 for approval. I move that the minutes subject to the amendment as a correct record. All in favour? Any against? Any abstentions? No. So item 5 is questions from members of the public, and I'm really pleased to say that the first time, certainly since I've been chair, and I don't know about the previous chair, we have two questions, which is really good, and I will be encouraging others to be filtered in this direction going forward. So the first, if I'd like to turn to Henry, if you'd like to read out the first one.
So we've received one written supplementary question from Anne Russell, who has requested it to be read out on her behalf. It reads, while the Council has cited evidence reviews suggesting water fluoridation is safe at permitted levels, many of those reviews did not specifically evaluate the potential neurodevelopmental impacts during key windows of vulnerability, like fetal development and early childhood. Given the emerging research indicating fluoride may be a developmental neurotoxin even at relatively low levels of exposure, how does the Council plan to thoroughly investigate and address these specific concerns before moving forward with a fluoridation programme that would involuntarily expose all residents, including pregnant women and infants?
Matt, could you like to give a response?
I will, thank you. So you'd have seen my original response to Ms Russell's question. As yet, the Health and Wellbeing Board hasn't made a decision around fluoridation, but I know the board is supportive of that. But within my original question, there needs to be a process that needs to be followed in terms of a feasibility study and also a public consultation. So as with all public health interventions, we'd review that evidence, keep up to date, look at what the science tells us, and that would inform our decision at that time. Also worth noting out, there's soon going to be a public consultation for fluoridation in the northeast of England, so that will provide another opportunity, even if you live outside the north of England, to take part in that consultation. So that constituent is more than welcome to obviously feed into that consultation when it takes place. Thank you.
We had a question from a councillor, but did that councillor submit a supplementary?
No, supplementary questions was received, Chair.
So members of the committee should have received seen the question and the response given by the Director of Public Health. So we now move on to item 7, which is the Herefordshire Safeguarding Adults Board Annual Report 22-23. And I would ask Kevin Crompton, Chair of Herefordshire Safeguarding Adults Board, who, as we know, is attending remotely, to present the report. Thank you, Kevin.
Thank you, Chair. Obviously, assuming people read the report, so just a few introductory remarks from me. Firstly, obviously to note that this report, we're now nearly at the end of the following year. So apologies that the annual report didn't come to you sooner. I think a bit to do with transition. I took over the chair about April last year, then obviously elections, and it's taken us some time to just get back on track. But the previous chair is in the room should he wish to contribute at any stage. Ivan. So a couple of key points. It's a year earlier, and ironically, about a week ago, we have done our review of 23-24. So obviously, there's a lot moved on since this report. I think it's worth noting in the report a couple of key points to notice. Firstly, that I think this report dominated by the post-pandemic and the board getting back to more of a business as usual. But it is worth noting that in terms of national data, the performance data wasn't collected. It was voluntary during the pandemic, so that the data in this report is 1920. But I can report, and when I bring this year's annual report, data is now back on track, and we've literally just received about a week ago updated data, so which we can compare performance in the county with similar authorities. I think point 7 for me is really important when it comes to safeguarding concerns. So the overall number fell. 47% of cases, the issue was in the individual's own home, and the abuser was known to the victim. And I think with a lot of self-funders in the system in Herefordshire, it's a characteristic of the system. I think it's a challenge for the Safeguarding Board. How do you get line of sight on things that are actually happening behind the closed doors of people's houses? And this year we're having quite a lot of discussion about raising awareness in the community that if they're concerned about a vulnerable adult living near them, to encourage people to check on them, for example. So we're looking into that. I inherited some for this year some intentions from the partnership prior to me, and work on transition of children who are exploited as they move into adulthood. And in fact, transition in general is a theme for the partnership, and it is being taken forward this year. The 2 projects mentioned in paragraph 9, the census of experience and the review of Rusty thing, that has been completed, and unfortunately, this is like a trailer. The results we will be putting forward in the next annual report, but we had a presentation recently. In terms of the partnership, to be honest, everything is in place. If we have some challenges, they are identified in paragraph 10. Delivery of regular performance data, in particular multi-agency data, is still a challenge, and engagement with individuals, getting feedback from service users is also a challenge for us. Sorry, bear with me, Chair. Sorry, colleagues, I have one dog in the room with me who just decided he wanted to scratch his bed, so apologies for the background noise. He'll stop there. Just on a lot of trade for this year, I say we've continued some very important work building on the 22-23 year. We have done follow up to the safeguarding adult review of individuals with multiple and complex needs, and we are looking at the whole theme of homelessness and rough sleeping again. Performance data is now more up to date and being refreshed. And one thing very interesting I will share is in terms of performance of adult social care and partners, the data is now being refined to pick up what you might call early help, an early help offer within the adult social care world. These previously have been on the system, been listed as no further action, but actually more refined data is showing that NFA doesn't mean no further action. It means they've been referred to other places. So there's some good news there. And one thing, again, I'll trail, there's a lot of work now being done on a self-assessment, which includes a self-assessment of the partnership and its effectiveness in preparation for a possible CQC inspection. That national, the inspection regime is now in place and they could visit us at any time. But some issues are continuing and are ongoing. Workforce issues and workforce supply is an issue across social care for partners, adult social care capacity. And as I say, this getting a line of sight on what you might call hidden abuse, as I say, what's going on in people's homes. And quite an interesting statistic I picked up recently for the Community Safety Partnership about domestic abuse cases, and a small but worrying number of cases which involve over 60s, one of whom has a form of dementia. And what as a partnership do we do about those instances? So that's come on this year. I'll stop there if I may, Jan. I'm happy to take questions. It's always difficult to be introducing a report for a year when you weren't in the chair, but I'll do my best to answer questions.
Thank you, Kevin. I've got a couple points I wanted to raise, but really, when you talked about item 7, the number of reported safeguarding concerns fell.
Yeah.
You've got 47% of reported cases took place in the individual's own home, and 41% the abuser was known to the victim. So when we're talking about the number of reported cases falling, are you talking about the number of reported cases that were found to be worthy of following up, where there was abuse taking place? Because certainly the figures that you're quoting here, you say actually 41% the abuser was known to the victim rather than the accused abuser. So
those figures, Chair, on pages
14.
16, 17, 80 of the report, or 28, 29 thereabouts of the agenda. It is, I think it's the overall number of concerns that are reported has fallen
right
over those years. I'm trying to get the exact figure. So bearing in mind this would be 1920 and data wasn't collected. So I'm just going through the report, apologies. But it will be the overall number of referrals that's fallen.
Okay, so it's not the overall number of cases where it has been proved that somebody has been abused.
No, it's the proportion of those. So the overall number of cases being drawn to our attention fell. But of those cases drawn to our attention, those figures of 47, 41 refer to those that were actually investigated.
Okay, thank you. I was going to ask Christine, but when she comes back in, about the issue around the difficulty in engaging with those who have been safeguarded, and what we can do to actually get a better feedback from those people.
Yeah.
Thank you, Chair. So in terms of any safeguarding inquiry, we will always seek feedback, and these are the ones that adult social care investigate. We will always seek feedback to ensure that the outcomes that someone had set as part of making safeguarding personal, that we have achieved those outcomes for them. So there is some feedback in terms of that, and their overall satisfaction with the process of the inquiry, and that's obviously needs to be done sensitively. So we do get some feedback, I think, but I wouldn't like to say that it's comprehensive, and that is something that we have picked up as a board and want to do more work around.
Okay, thank you, that's fine. And the other thing I was going to ask, page 27 or 15, I don't know, where it says progress, it says the making safeguarding personal continues to be a focus for the board. Audits have been conducted and findings evidenced that although MSP is embedded into statutory agencies, understanding across the wider sector requires improving. What plans do you have in place to do that?
So, I think this is probably connected to all the work around Talk Community,
right,
and working with partners in the voluntary sector, Chair.
Okay.
And I think it's as Harry's just said, feedback is asked. We ask people for feedback. It's encouraging more people to give that to us. And I think MSP is an ongoing thing, that you're always working with organisations to try and make sure their approach is sensitive to the whole making safeguarding personal approach.
Thank you. Matt.
Yeah, thanks, Kevin. It's just building on that. I know in some areas I've worked, the voluntary and community sector often talk about wanting more safeguarding training. So it's just building up on that, because obviously Talk Community isn't the voluntary and community sector itself. It's almost a vehicle for that. So I was just wondering, is there still a need in that? And I was wondering whether that's come out in any sector, the VCS sector reports that we've been undertaking about that requirement of more safeguarding training, and what that uptake is like more broadly across the VCSE sector.
I don't think we've actually got data on that, Matt, at the moment. Other college in the room may be able to help me.
Okay, it might be a need then we might need to look at.
Yeah, it might.
It's just what I've experienced elsewhere, Kevin, that's all. So I was just wondering if it's,
if
it's been borne out in Herefordshire as well. Okay, thanks.
Yeah.
Ivan.
Just hoping to help out a little, Chair, if I may. I'll just to acknowledge I was the outgoing Safeguarding Adult Board Chair, as Kevin has said. So a couple of things on engaging with service users. For the last few years, several years in fact, we've tried a number of different ways of engaging service users, and we did that for this reason. As the Director has rightly explained, the service itself does engage with and seek feedback from those who are in need of safeguarding. But in fairness to the Assistant Director at the time, she also wanted some additional external engagement. So, you know, to use the phrase, she didn't want to be seen only to be marking the local authority's own homework. So we've tried a number of attempts at that through the voluntary and community sector, through Health Watch, and a couple of other things. And I happen to be a member of the Adult Safeguarding Board's Chairs Network nationally. You know, it's not an easy thing to do. So I wouldn't want board members to think that there is nothing going on. It is more that the local authority has a desire to do something that complements and supplements its own work. So there's that point. And just to raise a small point, if I could, Chair, just about the numbers, the 47 and 41%. The board did and continues to explore what that might mean for the profile of domestic abuse. There are, depends how you look at it, there are 10 or 11 categories of abuse that are recorded under the Care Act. One of those is domestic abuse, but there are also a number, for example, physical abuse, sexual abuse, emotional abuse and financial abuse, which if perpetrated in your own home and by somebody who is caring for you, arguably presents some domestic abuse. So there is, and again, I discussed this nationally, there is a need to make sure that we understand the profile of that, both locally but regionally and nationally too. So just a couple of points which I think are important. And then the last point, referring to Matt's question about the voluntary community sector, I certainly annually presented the annual report to HVOS, and there are conversations ongoing between the business unit and the voluntary community sector about what a training offer might look like. So apologies for interfering, but Kevin's right. He's presenting the report for the period that I was chair, so hopefully that's helpful.
That's fine. That's fine, Ivan.
Yeah,
Not a problem.
Chair. Yeah. Chair, if I may, that's really helpful. And I do note from my notes of our review meeting last week, a small team is being put into place under the principal social worker to increase our capacity in terms of getting feedback from users. So within Hillary's setup, there's a new focus. And I don't know the detail, but there was some work done with Health Watch to try to get feedback, but for reasons not best known to me and good intentions, it didn't quite get off the ground. But I'm always willing to look again at good ideas.
Well, Christine's now back in the room, so I can ask the question of Christine as to what actually went on.
Yeah, so we had to use a process where the safeguarding team would get consent in Mosaic from people at the end of their safeguarding episode, and we just didn't get many people consent for us to follow up and take it on, and we can't really access people without that. So yeah, it was really down to people not wanting to do it.
I understand. Fine. Anybody else? Yeah, Jane.
Thanks, Kevin. A couple of questions. It seems like referrals going down is a good thing, so I'm just checking with you. You think it is a good thing, and also in terms of the timeliness of the report from the year that's just about to finish, are we going to get it a bit earlier next year? Then I've got one other question. You've answered those.
Okay. So the second question is easy. Yes, I will be working on this year's annual report at the end of this month. I think it would be good to get it to your first Health and Wellbeing Board, either last of the summer, that would be optimistic, but first one in the autumn. I think it's really important. Yeah. And as I say, quite a lot of quite important things are now happening, like up-to-date information and so on. So sorry, your first question again, Jane, was?
It was referrals are going down. Is that a good thing?
Yeah. I'm going to say it's a difficult question to answer, isn't it? Yeah. Because you don't know what you don't know. I think the data we've got this year also is important. We need to pick up this early help stuff. We need to have a proper self-assessment, proper understanding of what's happening out there. You know, what is being done with individuals before they get to that referral stage, before having to make a referral in. There's some interesting things in the 22-23 data that literally I've had half an hour to discuss in the last week. And I think when we bring an analysis of that data, I can bear in mind your question and discuss with Hilary and colleagues and give you a more informed view. So we've got data from 2019-20, then the pandemic, and then you've only just got the new stuff. It's difficult to say. As I say, I think the interesting thing for me in Herefordshire is with a high degree of self-funders, the line of sight for agencies is not necessarily, in my view, the same as if you've got a high number being directly supported by, say, local authority services or directly commissioned by. So there's some interesting dynamics in this count.
There is. Thank you. And then my last question, and it might be one for you to answer when you come back, actually, as you're still searching through the data. But is what's your top worry?
Oh, the top again. I think that that statistic from the Community Safety Partnership about over 60s and domestic abuse, I worry about, as I say, you don't know what you don't know, and in this environment. So I probably worry a bit about that. And then probably from the partnerships point of view, a lot of work being done from last year with continuing individuals with complex needs. You know, where homelessness, drugs abuse, etc., they come together. And obviously, given my other role in the county, that transition from children, young people into adulthood, you know, that would be obviously something I'm looking at. I want us to move forward on that joint exploitation strategy, old age exploitation strategy.
Thank you, Kevin.
So I think Simon just made a comment in the chat. No, can't see it now.
Hilary.
No, it was just an email to you, Kevin.
Oh.
Okay, thank you.
Hilary.
Sorry.
Do you want to share this?
I think in
I see. Yeah. No. All right. Yeah. Good point. Ivan's saying that one of the issues around the timeliness of reports is that the national data sign-off takes conventionally takes through to November. So that's a good point. So, we'll look into that. I will let you know when, given that point from Ivan, I'll let you know if that does impact on the timeliness of bringing the 23-24 report.
Thank you. Hilary.
Yeah, I just wanted to pick up on the question Jane said about the number of concerns. I think if you look at the graph at the bottom of page 17 of the report, the bigger question for me is the conversion from those concerns into actual inquiries, and then whether abuse is substantiated from those inquiries. I wouldn't want to stop people referring in concerns, because actually that should be informing what we then do in terms of our awareness raising and potential work with the voluntary sector and others, and talk community and others, in terms of how we address some of those concerns, because they may not reach the threshold for safeguarding, but they're clearly the concerns that people have. So I wouldn't, it's always a balance, isn't it? I wouldn't necessarily want to see that number reduce. I do want to keep an eye on that conversion between concern and inquiry, and then what's substantiated. But I think we can gather a lot of intelligence from those concerns. Whether we have historically done that sufficiently, I'm not sure. But I think there's a lot of really good intelligence there that we should be gleaning, that is, as I say, doesn't necessarily meet that threshold for safeguarding inquiry, but there's still things there that we should be aware of and responding to in a partnership way.
Yeah. Indeed. And can I say, Chair, another thing we've done recently, we have had a session with the group that are putting together this self-assessment, and I have to say one of the things we're trying to do, and Hilary is trying to do, is capture really good examples of partnership working and really good examples of the community working to help safeguard adults. And I won't go into detail, but there are some, you know, about people in villages, people in post offices who've made this their business to look after a vulnerable couple, for example, and so on. I think there's a lot of good things being done through Talk Community, through communities that you know, we sometimes don't spend enough time capturing that good stuff, and so we can actually celebrate some of the work that people are doing.
Yeah, I would agree with you, Kevin, absolutely. Another question that I had was the evaluation of Safe Voice. Again, I think this is probably aimed at Christine, where you said it was not possible, has not been possible due to the lack of service user participation. Can you elaborate on that a little bit?
Yeah, so to get consent for us to follow up with the individuals who've been through a safeguarding process, we asked the safeguarding team, when cases were closed, to ask the individuals if they'd consent to be contacted about the experience, and basically not many people consented. So we maybe get one a month, if that, right, which is not really that significant. And we can't do a lot more than that as an outside agency to know who are these people and you know, to capture them at a time when they've come through the process when it happened. So I think there's probably more we could think about doing, but it'd probably have to be done as part of the process within safeguarding, the team that are doing the investigation. But then there's something about all the people going through the process. If it didn't meet a threshold, I don't know how we would capture any views on that.
No. And I presume we don't know whether this is the same sort of problem across the country, really.
I don't know. I'm not sure if Kevin would know.
No. I suspect if you've hit this issue of consent, Christine, other people have.
Yeah.
But I can check at the next Midlands Network meeting to ask whether this is, if people got an issue.
Yeah. The only other point I was going to mention was that the training courses that you put on, in the main, have been really well attended.
Again.
Page 37, stroke 25.
Yeah. Sorry, I've lost my. I'm sorry, I haven't got a split screen.
So the domestic abuse.
So, I mean,
yeah, the domestic abuse case, which was West Mercia Women's Aid, it was 107 people attended that, and the trauma-informed practice 164, and then you've got fabricated and induced illness 167. I mean, they're quite big numbers.
Yeah, they're good. They're good numbers, Chair.
Yeah. A couple of them that I think possibly we could have done. It would have been nice to have had more people there, but I think, you know, overall it looks quite good.
Yeah.
Anybody else?
Of course, we have quite a lot of single agency training going on around safeguarding across the piece as well, which will be recorded by individual agencies.
Right.
I guess the question I will want to ask next year is, given those numbers, what was the impact in terms of practice, people's lived experience? I think that for me is always the key question around when we do training and development. What changes? You know, has it made an impact? Certainly. And again, I know I'm going back on the brief, you know, my year as it were, but we did hear some really good stuff which we'll report in the next report on the impact of that work around homelessness and the way that the teams have reviewed the way they're working. I think particular note appointing, getting a female member of the team has improved the engagement with women who find themselves homelessness or street sleeping. Some really good work has come out of those projects that were a legacy from the last year's board work.
Yeah, I agree with you. They have, absolutely. Does anybody else have any questions on the report? Right, go back then. So the recommendation is that the Health and Wellbeing Board considers the report, and we now go to the vote. All those in favour? All those against? Any abstentions? Thank you.
I think I abstain by virtue of a conflict of interest, Chair. So
you're virtual anyway, so you can't vote.
Well, there we go.
If you're not there, you can't vote.
I'll bear that in mind, Chair. Thank you very much.
Okay. Thank you. And thank you for giving your time to come. Item 8 is the update to the board on the Best Start in Life implementation plan, and to present this is Matt Pearce, and I believe also Julia Stevens will support him with the children, young people and sexual health. Okay.
Thank you, Chair. I'm only going to do a brief introduction. I'm going to hand over to Julia. So I think we last brought the draft implementation plans for our two priorities in December for mental health and for Best Start in Life. So this is the first meeting where we're going to do a bit of a deep dive into the Best Start in Life, and then it was agreed at the last meeting that the next meeting will be mental health and alternate therefore going forward. So it's really important, I think, to spend a bit of time on this because this is one of our Health and Wellbeing Board priorities. So there are lots of papers in there, but it's split into 4 parts, if you like. So I'll just give a brief overview, and I said I'll hand over to Julia. The first is very much a summary paper, just detailing very much what I've just said. The second one is then about a performance management framework. So a lot of this is common sense, but as you all know, the last health and wellbeing strategy, we really wanted to make sure we put quite a robust kind of process in place for monitoring impact and implementation of the delivery plan. So that's really what the performance framework is all about. Reporting by exception and highlighting to the board the key issues that we might need to address and unblock potentially as system leaders. There's then a covering note around the outcomes dashboard that we're still developing. So again, how we've identified the metrics, the key indicators in terms of monitoring that progress. And then the final report is about the outcomes dashboard itself, which again, the board can use to monitor to progress. That's kind of the 4 areas of the report. I'm going to hand over to Julia to go into a bit more detail, and then we're happy to take any questions.
Okay, thank you, Matt. Yeah, just a brief overview for everybody and a reminder, in case it might have slipped your mind, that the Best Start in Life is a national programme, so it's aimed at giving our children 0 to 5 years, literally what it says on the tin, a best start in life. And working with partners across the spectrum with regards to making that happen in Herefordshire. We've got some really exciting developments, which I'll talk about a bit later operationally, which are really happening now in the community that really brings this plan to life. Whereas at the moment, you're looking at sort of paper versions and monitoring. I can give you a bit of a flavour of what that really looks like in practice, which I think is really useful. So as Matt said, since December, when the paper was brought to you previously, between then and now, we have been working with various partners across the system to develop key targets against the actions. And I can safely say that we've got a selection of targets now, which we'll share with you at the next partnership board in September, against the actions. And we've got lead professionals that are responsible for reporting on those targets. And I think we're 90% there now with regards to the targets and the lead professional that's going to be able to support delivery of and report that back to us, which obviously we will update you on. We've been developing a performance monitoring framework, which Matt mentioned, with regards to how we're going to ensure that we're on track to deliver what we say we're going to deliver, how we're going to monitor it, and then the challenge or the pushback as to say, you know, where are we at with that? So what we've done is we're going to RAG rate where we are at with our targets, red, amber, green, very familiar RAG rating. And at the moment, we're already on some of those greens in regards to we're progressing really well with some of the targets that are already being rolled out or at least being implemented. So that's really positive. Some of the key things that I just want to bring to life, I think, from a plan which is on a page, but what does it look like in reality? So, for example, a really exciting development is we've got our contracted provider of our 0 to 19 service, which is Wye Valley Trust. They are going to be rolling out a 4 to 6 month oral health and weaning check for our youngsters. They did it as a pilot project a year or 2 ago, but we've developed that into the new service contract now. It forms part of this Best Start in Life implementation plan, and they are going to be doing that check universally to all our parents who have a baby 4 to 6 months old. That's really about promoting oral health and weaning, healthy eating, etc. And equally, they're going to be rolling out a 3-year preschool check. So these are 2 additional health checks on top of the 5 mandated health checks that this service have done historically. That's really going to support some of the outcomes for our children and young people in order to give them the best start in life. So that's something very practically on the ground that we're going to be able to come back and feedback to you on how that's progressing. One of the other things is that we're developing a healthy schools and healthy talks framework. So that's going to be targeted at all our primary schools and all our high schools. So that's encouraging schools to be part of the framework, to be part of a healthy school initiative for Herefordshire, really working to support schools to support their pupils in health and well-being, tackling obesity, oral health, all sorts of things within that framework that they work towards and that we support them with. And that again will link in with our public health nursing service that work very closely with schools, and also really to support those pupils that really need it and to support those schools that really need it, because we know schools are suffering with regards to the support that they can get in tackling some of the problems that they have with their children and young people's health and well-being. So that's another real example of a very practical project that's going to be rolled out. We're piloting 5 schools imminently in March, and then in September we hope to offer it out to the broader school community and encourage take-up of that. So that's a really exciting and informative way that we can support our schools and our children and young people. And just another thing to highlight, I obviously can't go through everything because we'd be here all day, so I've just picked out a few. The other one is that we're working with our special schools to take up supervised toothbrushing. So you might be aware that supervised toothbrushing was rolled out 2 years ago in Herefordshire, and I was told by many professionals that there was no way you were going to get schools and early years nurseries to take up supervised toothbrushing with the challenges that they already face with the work that they have to do for Ofsted, etc. And I can say that we have got 40 of our schools and earlier settings that now routinely do supervised toothbrushing with our children. And some schools have come back to us and said, can we roll this out across the whole school? So this is really a really good example of how public health have steered and encouraged, and we know that this is an evidence-based practice that makes a difference. So although it's a long-term review, if you like, of how that makes a difference, we can't imminently say, oh, that amount, a number of children won't have cavities, etc. It is a long-term process, but we know that if children brush their teeth twice a day, that makes a significant impact on their health of their gums and their teeth, etc. So the fact that our special schools who have added complications and obviously added health complexities with the children, that they want to take it up as well, that's really good news, and also forms part of obviously the Best Start in Life action plan. So those are a couple of really I think the word is real examples of some of the practical stuff that this plan is delivering on the ground. Anything you want to add?
Just on the outcomes dashboard, I think it is quite useful just to bring the board's attention to that. So I think that's Appendix 4, I think it is. These are some of the key metrics. We've tried to bring together nationally published data that we have available through the Public Health Outcomes Framework and other data sets, but also local indicators that we have and metrics that are delivering against some of those actions, just kind of bring them all together. And we tried to be quite selective with the indicators as well. So what data is actually indicative of the outcomes it's going to deliver. So some might be quite direct in terms of what we commission, in terms of the visits, etc. Some might be more complex, requiring multiple partners to influence, whether that's mental well-being, whether that's childhood obesity, etc. So it's worth just casting our eyes over those. Some of those might take a little bit of time to change. So they're not going to change over a period of 12 months, and we know that, and it will take longer. But it's something we really need to keep a watching brief on. Some might change sooner, but I think it's a really useful kind of oversight, if you like, of the kind of the entirety of the programme and what we as a board can look at and keep track of. But no, nothing more from me, thank you.
Yeah, Julia, thanks. That's really interesting, particularly the thing about supervised toothbrushing there. I'd like to ask, what is it you think made the difference? So people were sceptical about the possibility of rolling it out. I'd love to take some messages back across the other side of the border into Worcestershire and see if we can develop some of the learning there, because obviously children's oral health is one of the main ICS strategies that we've got for all children across Herefordshire and Worcestershire.
Thank you. Yeah, actually Worcester have contacted us with regards to how are you doing it, because there are challenges over there. I think one of the things is that we've got really good relationships with our schools and early years providers. Some of the team that work in public health that deliver this used to work in children's, so we've got contacts already, so I think that helps. And I think the approach, I think schools and nurseries very much think that it's a very time-consuming activity on top of something that they're already doing and rolling out, where when they realise that you don't necessarily have to have water involved, you know, they think that they're going to take 30 children to the toilets to brush their teeth and all the hand washing processes, where in fact you don't have to. You can sit round a table and you can, you know, spit into a paper towel, and there's a whole process for doing it very quickly. It doesn't involve water. And I think once they realise that it doesn't take a long time, it can be done very quickly, very efficiently, and it's just integrated in part of the school day or the nursery day, then they will run with it. And then, of course, word of mouth, because parents absolutely love it. They like the fact that it's another selling point for the school or nursery that they are doing this. And that has encouraged more children to come to their nursery because they're specifically doing that intervention. So I think it's a win-win, but happy to have further conversations with you with regards to that.
I mean, yeah, fully support it. As the organisation that's now responsible for dental commissioning, there's absolutely no substitute for prevention, is there? And good healthy teeth. So we fully support you and like to work with you as much as we can to ensure that's successful. Can I just make one other comment as well? The framework as a whole, I think it's really clear, and it was fantastic to see the direct alignment to the integrated care strategy that we signed off last year. I was just going back through the plan on the page and all the kind of priorities that we put down there, and they're all there. So we've got a really clear alignment, a mechanism here for monitoring our 10-year long-term strategy as a system going forward. So just sort of endorse that and support that as well. Thank you.
The points I wanted to make. Firstly, your enthusiasm is very infectious, I think. And I can't imagine anybody that's going to refuse you because you are such an enthusiastic person. I think, you know, that presentation to us was very, very good. And the way that you've explained how schools can do this without using water, etc., I think is really good. So thank you. Oral health for me has been a bit bugbear ever since I came onto the council back in 2015. So I know that we've now, it appears, have got 2 new dental practices opening in April. I just wondered if someone could tell me where they will be.
I think I might have to pass over to Harpal to answer this question. Who's on the call?
Hi, thanks, Julia. So we're still having those conversations where the locations will be. I think that data, that information is available now, Chair. So I can get that for you. I'm not sure on the exact location at the moment.
If you could let me know, I will be very grateful. Thank you.
Yes, I will. Thank you.
I think that the way that this has been laid out with regards to our priorities is very clear and I think easy to read for anybody, and it's really been laid out really well. I'm very impressed with it as well. So thank you for that. I don't think there's anything that's red, is there? I don't think there is. No, not yet. Not yet. So, yeah, I mean, I think, well, I mean, if you look at to be fair, if you look at the dashboard, obviously then we have got some red lines regarding dental, and we're not doing so well on children overweight and vaccinations, MMR, etc. And the number of children in care, immunisations, is not as good as it perhaps could be. Do we? How proactive are we on this?
So it's picked up by the Corporate Parenting Board, and there's a piece of work going on at the moment around immunisations and also dental health checks for children in care. But that's certainly something that the Corporate Parenting Board are very focused on at the moment.
Going back to the MMR, I mean, I know there was a question by a councillor regarding the measles issue earlier in the meeting. We obviously have sort of certain groups of people that are hard to reach, and what plans do we have to go out to them to get their children vaccinated rather than rely on them coming to us?
Yes, I think there's various different programmes going on across the county to do that. So I know there's a bit of a national recall system at the moment. So GP surgeries are being told kind of who they can actually send letters out. That's a good question in terms of the seldom heard and how we reach those in those rural communities. I think that's something probably I don't have the answer to unless David does. But I know Rob, my health consultant in public health, he'd probably have a bit more of an idea about how we're going about do that. David, are you familiar with?
Yeah, well, a little bit, but not as much as perhaps should be. But we put a lot of emphasis across both counties into prevention outreach services, as we call them, where we're taking services out into the community and sort of, I keep wanting to say talk wellbeing, but is it talk wellbeing? It is. Yeah, sorry, I get confused sometimes. And there's so like the Maylord Centre opening, for example, the High Street. We've also got a van that goes around out into communities, goes to the agricultural market to engage with farming communities. You know, we can take services out into communities, and you know that we do certainly do some vaccination work. I know we've been doing COVID vaccinations through outreach services, so I don't know whether there's an opportunity to do.
I believe that you did COVID vaccinations for sort of Romany people. And I just wonder whether you were doing the same for them with MMR.
I would have to check specifically on
It
MMR.
it seems like a no-brainer to me that where we've got sites that we should be trying to access them and get those children vaccinated.
Yes, indeed. The complication, which is there's always a complication on these things, isn't there, is the governance and the medical legal arrangements around who's covered to vaccinate for what in certain environments. So general practices can vaccinate all sorts of people. We've got sort of special arrangements for COVID vaccinations, but I'm not sure about whether MMR and you know other similar vaccines are covered by the same arrangements, because there's kind of a national contract for some of these things. So that I can't answer specifically. I'll have to come back to you on that one.
Yeah, I'm pretty sure there's some work going on because I've raised this very point myself. So what we can do is maybe note that as an action, and we can bring that back to the board and confirm or follow up after. Happy to do that.
A comment really rather than a question. So I was on leave when this came to the One Herefordshire Partnership, so this has been my first opportunity.
You were trekking?
I was trekking out in the cold. And so it's been my first opportunity to have a really good look at it, and I have to say I'm really impressed. I think it's come on such a long way. There's obviously a lot of planning, all of the actions and the targets that have been brought together. It's all really clear. So really well done. And then just one point of detail in terms of particularly childhood obesity. Has that improved? So that figure for 22-23 for 45-year-olds, which is 19.4, because I thought the last time I looked at this data, actually we were at, if not higher than national average, and we look like we are below. So has that already improved? But it may well be I'm just misremembering some data.
We've got Kristen here, and I think we've got it on the end of the agenda as well. But Kristen, are you able to cover that specific point?
Yeah, so I think later on the agenda we have a presentation specifically looking at this, but that's fine. Yeah, so I think we're very much following the national trend. So the trend has come down slightly, and we are following that trend since COVID years. So it does look on a downward.
Yeah, it's good. It's just that the benchmark is, we are. I mean, it's 3 percentage points, but it's all worth having, isn't it?
Yeah.
So,
I don't think we're statistically significantly higher, which is what we were. And I think we're now back on there.
I can't just add on that, because I've looked at this previously when we did an ICB board deep dive into health inequalities. The correlation between deprivation deciles and childhood obesity is frankly, it's almost directly correlated, isn't it, Matt? From more deprived communities have more childhood obesity than less deprived communities, and so that's another one of those kind of targeted intervention groups that we should be trying to work with.
Yeah, I think the interesting thing.
do know adults though, don't we? We have figures for adults.
It's adult obesity is about 30%, give or take, and then adults overweight or obesity were nearing 70%. So it's quite significant numbers, yeah.
So between from 10 to 11 at 35%.
Yeah. Yeah.
By the time we get to adults, you'll double that again.
Yeah, so reception to year 6, nationally, we always see a doubling of prevalence of obesity. And then adults, yeah, it's about 5%, well, it's about 30% in year 6, isn't it, what we've got in front of us. So, yes, a bit more in adults, it goes up. But the biggest, I mean, at the end of the day, prevention, that's why the best start in life is actually really important. If we can get the 0 to 5 years right, then obviously we prevent those in reception year from becoming overweight or obese. So it's really important we get that right to begin with. And then clearly something's happening between the ages of 4 to 5 and 10 to 11. And it's not just schools, and I don't want it to come across that it is schools, actually it's a wider societal problem here that we need to address. But clearly it's something that we will probably see over the coming years as some of these children move into adulthood, early diagnosis of type 2 diabetes and those kind of things. So it's something we really need to get on top on, both locally and nationally.
So, it's not necessarily this meeting, but the health service in general, are they prepared? Onslaught of type 2 diabetes that's coming their way or has come their way, and all the associated issues around heart problems, etc., as a result of this increasingly large number of people who are getting larger and larger.
So Jane might want to add to this. Are we prepared? I would probably say we are preparing. We are cited on it. We do a lot of work. CVD is going to be a cardiovascular disease prevention is going to be a big focus this year. Doing a lot of work on kind of pre-diabetes, trying to identify patients. We're part of the National Obesity kind of reduction program. Could we do more? Yes, absolutely. We could do more collectively as a health system and wider partners. But we recognise it's a major problem and it's a big part of our long-term planning.
Yeah, I mean, if it carries on at the rate that it's at, then there's no doubt that we won't be prepared for it. We won't be able to either fund or have the workforce to deal with that level of demand. But that's why the prevention agenda is so really important. If I can just give the example of lots of people know John Burnett, and he won't mind me telling this story. Who's our communications manager? But he was a man who was in type 2 diabetes and took up running and is now fit and healthy. His diabetes reversed, and these things are possible in secondary prevention as well as primary prevention. So it's why that prevention agenda is so important.
And as a trust, do you ever do a sort of an audit on the people that are coming through your door as inpatients, as to what percentage of them their issues are related to their diet? Or
I mean, causality is quite difficult to prove in every way, isn't it? But we certainly have coded information on the number of people who are diabetic, the number of people who are morbidly obese. So we have coded information on that.
Right. Any other questions? No? Okay. We move to the report then. We move to the vote then. All those in favour? Any against? Any abstentions? Okay. We move on to item 9, which is the Better Care Fund Quarter 2 and Quarter 3 reports. And to present this item, we've got Maria Gallagher, Transformation Improvement Lead for Community Wellbeing, who is attending remotely. Yeah. And Hayley Doyle, Service Director, All Age Commissioning, also attending remotely. And we're over to Maria. Or Hayley.
Hi. Yeah, having
Hayley first.
Yeah, I'm going to start, if that's
Right.
okay, Chair.
Okay.
And then we'll also bring in Adrian Griffiths, if that's okay, as the
That's
finance lead for the Better Care Fund.
Yep.
So you will be aware that the National Better Care Fund team determined the national reporting requirements for the Better Care Fund, and this year, the 23-24 year, there was no requirement to provide a Q1 report, but the deadlines and the dates for submission were set by the national team as mandated deadlines. So the Q2, Q3 reports have already been approved by the Director of Community Wellbeing, Hilary, and the accountable officer within Herefordshire and Worcestershire ICB, so that we were able to submit in accordance with the national deadlines. So today is really an opportunity for the board to note the contents of the report, identify any further actions that you wish the team to consider to improve performance, and feedback to us on those reports. So the templates that you will see at Appendix 1 and 2, they are national templates that require us to complete in those formats in line with the Better Care Fund national conditions. So the Q2 report this time focuses on a summary of changes around demand and capacity plans, and also gives some updates against the metrics, and Q3 collects the information against the metrics and our ambitions, as well as an update on our spend. So the data is set out and key elements set out within the report in relation to our performance on a number of the metrics, but there are some key things that really wanted to highlight for the discussion today. So we are, as a system, undertaking a considerable amount of work against all of the Better Care Fund schemes, but some of the key things to highlight: the focus remains on being able to support people at home and to be at home for longer, with avoiding either hospital admissions or avoiding the need for longer term care. So we continue to work on this area, and you may remember that we noted in our last presentation to Health and Wellbeing Board that the council were embarking on work around further developing their secondary framework for home care. I'm pleased to say that over the last 2 quarters, we've seen significant movement in relation to our home care market. We've increased capacity with new entrants, new providers to that home care framework, and we've seen the waiting list now reduced to just 7 people as of last week. So that's from a position in the middle of last year where we had over 100 people on the waiting list. So that's been a really positive move. What that means in terms of the system is that we are able to meet need quicker and respond quicker, but that should start to enable further flow through the system, and we're just at the point where we're hoping to see those changes come through. That also helps us with our position in relation to overstays within Home First, and moving those overstays onto their longer term packages of care. So that's been a significant change since we last attended Health and Wellbeing Board. Within that, though, we are seeing an increased acuity. So we know that some of the people that are coming through for home care are requiring a higher number of hours than in previous trends. So we are seeing increased acuity and complexity coming through that process in terms of delivering more hours to fewer people in some cases because of the increased complexity. So that trend is continuing. We have also been working across the system with our ICS and ICB colleagues around our discharge to assess services, and you will note from the data that we are still on a journey with our reablement services in terms of driving improvements and ensuring that people remain at home 91 days after discharge into reablement or rehabilitation. So we're still on a improvement journey with that. But we are, as a system, we've been having something called a discharge to assess sprint, which is where we've initiated a significant programme of work to address the challenges that we've seen through our discharge to assess services. That is including a complete review of all of our pathways. It includes with working with hospital teams from point of discharge, our occupational therapist teams, our reablement offer, and the pathways through the community access team into service, and then a review of our Home First and Hillside services currently delivered by Hoople. We have had an increase in commissioning capacity to work very closely with Hoople to try and make some of those changes and work very much alongside Hoople and our ICS colleagues in the redesign of the service specifications for both Homes First and Hillside. That work is continuing at present, and we'll be reporting into the Discharge to Assess board from next week. We also have a system have identified that there continues to be issues with the data and how we record data and how we get a real accurate picture of our Discharge to Assess data. And we are now appointing a data specialist that will be hosted by Taurus and have a first draft of what we need to include in a Discharge to Assess dashboard, which will enable us to better track services, etc., going forward. And that work is ongoing. We have worked closely with Hoople about improving the capacity in Home First, and Hoople have reviewed a number of their processes and functions, and we should see capacity in the Home First service start to increase from next week, following a number of changes and consultation with staff teams delivering the reablement service via Home First. So that work continues with us working together both as council partners and across the ICS footprint to deliver those changes. So significant amount of work underway, but still some areas that we need to address and improve to be on track to meet our end of year targets, and we'll be updating you at the end of year in relation to those targets that are not currently on track as we move forward. We do see that the Better Care Fund represents significant investment in our core services, and we continue to work together to make sure we have a joint approach to our reablement particularly, and maximising that reablement capacity. The Better Care Fund partnership group has been re-established and is meeting regularly. That now will report directly into the Integrated Care Executive and then upwards to One Herefordshire Forum in relation to our governance and performance monitoring going forward. So some real positive changes since last time we came to board, but still some improvements to make around our reablement offer. I'll hand over to Adrian to talk about our finances in relation to the Better Care Fund.
Thanks, Hayley. There's not a great deal to say about finances up to the end of Q3 in respect to BCF services. You'll see from the summary table in the report that the 5 pools that make up the Better Care Fund are very close to break even, running a slight less than 0.5% underspend up to the end of December. The position has worsened a little bit over the last couple of months. As you might expect, some of the services are demand driven and those are busy months, but I think the final year report will show that it outturns on or very close to plan again. There are some pressures on pooled budgets that are outside of the Better Care Fund specifically, but again we're working to mitigate those pressures, and I don't think we'll be far away come the end of the financial year. Other than that, there's not a lot to say other than going forward 2024-25 won't require a full Better Care Fund plan. The current plan we're reporting on here is the first year of a 2-year plan, but there is a need for a refresh of the plan and in particular the financial plan. We haven't yet had the policy framework or planning guidance or requirements from Department of Health for that, but I sit on a kind of national forum for Better Care Fund where we meet regularly with Department of Health colleagues, and as part of that I had a request last week for us to participate in testing the templates both for the year-end reporting and for the plan refresh, and usually when those requests come out it suggests that the planning guidance isn't far behind, so we may get it by the end of the month, which will mean that we'll then be doing year-end and the year-end report and next year's plan refresh all in the same time frame, which is less than ideal. But as those of you that have done this for a while will be well aware that the planning guidance tends to come out any time between March and September. So earlier is better because we're actually setting a plan towards the start of the financial year we're actually talking about. So it may well be at the next meeting, or probably more likely at the end of the summer, we will be back not only with the year-end report, but this year's refresh plan as well.
Thanks, Adrian. So just one of the other areas to note, which is referenced in the report, is that in terms of our longer term care for residential and nursing care, we are working with the market to look at, and this was a cabinet decision at the end of February, to look at block book arrangements for our longer term residential and nursing care beds going forward. Primarily the reason around this is that we do have capacity in the market in terms of sourcing longer term care, but we remain having challenges around the affordability of that care. So this will move to an additional arm to our commissioning in terms of block booked arrangements, as well as the framework arrangements for spot purchasing to support the overall system.
A general question to Jane, really. When someone comes in, we're talking about discharge to assess, right? When someone comes in to hospital, whether it be as a planned admission for an op or whatever, or as an emergency, at what stage do you determine the level of bearing in mind that it's probably a fairly straightforward process? What stage do you determine the decision to understand what will be required when that person is discharged?
I mean, in a way, the principle of discharge to assess is you don't do that in the hospital. You do that at a later stage, so you discharge with support, and then during those few weeks of support, you then determine what the long-term care requirements of that individual are. So yes, of course, we have to do some work to make the discharge safe. But in terms of what those long-term care requirements are, I mean, that's something that discharge to assess is what it says on the tin. Yeah. Really, you're discharging them to assess them for their long-term needs. If that makes sense.
So what about someone that's, say, for example, it's a short term. So for example, someone that's gone in with a hip replacement, if you like, so he's going to require some form of support in the short term, because they may either have somebody at home that isn't capable of doing so, or they may be alone, or they may have stairs, or they may have difficulty getting their front of the house. When would you make that assessment and pass that information on to adult social care that this is what is required for this person?
Well, if it's elective care, I mean, it should be as part of their planning process, particularly something like a hip replacement. You'll do a lot of that work up front.
So that could be at pre-ops stage.
Yeah, it would be up front, and then obviously you have to then make sure things are as you expect them to be at the point of discharge.
Right. Okay. And we believe that happens now.
I wouldn't say completely consistently, but that's the approach.
Because that would obviously would help if it did, wouldn't it? Because in theory, adult social care would have in place what is required once that person is ready to be discharged. So you're not having that person staying in a bed just waiting for that package to be put in place, which might be for a short period of time.
For a planned elective care, I mean, the approach is that's all done up front. I mean, the complexity we have is with those generally who've come in as an emergency, so there hasn't been an expectation that they've come in, and those are the patients who tend to get more stuck in the system, the sort of things that Hayley was just talking about.
Right. Okay. Thank you. Oh, sorry.
Thank you. So first of all, thank you, Hayley, for that broader context that you gave as you presented, because there's a lot of that isn't sort of quite in the paperwork, and I know how much work's been done and how much progress you've made. So thank you for that. I think it's really positive, and it's really encouraging, particularly the things around the home care market. I mean, that's significantly different, as you say, to where we were last year. I think I guess the comments I'd make though would be because you talked quite a lot, Hayley, about doing things with the ICS, and I think when you said doing things with the ICS, really what you mean is that we're doing this as partners in Herefordshire, because this is something that's been delegated from the ICB to us. So I think it's just a terminology question. And for me, it's about what do we think will be different in 12 months' time. So I think as all the work that we're doing, that you and John and Hilary are leading on, that we understand. So in 12 months' time, what do we think is going to be different from where we are now, which includes all of those things that you talked about. But also, what are the metrics that we're going to be measuring? Because what we are reporting here are the national ones, and I think Adrian's made the point a number of times. They're actually not particularly helpful in many ways, these metrics. They've been around for a very long time. They aren't telling you everything that we need to know about the outcomes we're getting from the investment in the Better Care Fund and the value for money that we're getting from those pathways. So I think what I would really like to see as part of that report that comes back. I'm not sure I agree with you, Adrian, actually, when you sort of said it's not ideal doing, closing down this year and next year's planning together. I think that's exactly what we want to do, is we understand this year and we do next year's plan. So I think what would be really good to see is that broader plan with a broader set of metrics that you say we are going to be reporting those through into our Herefordshire integrated care executive and One Herefordshire partnership, and that would be good to see those reflected here. So it's a broader set of things than just the national indicators, because I think they're not adequate for our purpose, particularly in terms of, say, outcomes and value for money and general system flow. Yeah, that's what I'd like as a recommendation.
Thanks, Jane. Yeah, so the data analyst that will be hosted by Taurus will be leading on those wider metrics in terms of what we report on. So as I said, there's some initial draft around what that dashboard needs to look like, but we can bring that back here as well as it's developed. Yeah.
So yeah, I'd like to specifically request that we also apply a health inequalities lens to the dashboard as well. So we don't just look at global population numbers, we look at the different elements of healthcare inequalities, whether that's deprivation, whether that's ethnicity, whether that's any other group, whether people have got underlying health conditions, learning disabilities, housing issues, etc. We have a proper look through a health inequalities lens, so we understand exactly where we'll have the biggest bang for our buck, if you like, on the interventions in response to what the data is telling us.
Can I just ask, are the voluntary community sector helping deliver this plan in any context?
So we don't currently have a commissioned service through the Better Care Fund delivering specifically on the discharge to assess services, but we work closely with Talk Community through all of the various options there. And the voluntary and community sector are very much linked into our prevention offer, community activities, etc. In the communities.
Would there be potential for them to be more engaged or better positioned to support help?
Definitely, that's something we can explore how we do that. Yeah.
It's just organisations like Age UK would work in this space as well and offer wider services that they do as part of their day job. And I think some of the offer is sometimes underappreciated and not necessarily valued because it's not directly delivering a certain funding stream, but the wraparound services. I mean, I know they've been involved in getting people home from discharge and actually supporting them reintegrate back at home. So I think there's more here from the voluntary sector. I know you're reporting against a very specific template and there's not necessarily room to recognise the role of the voluntary sector within quite prescriptive templates, but there's definitely a role and there's definitely added value here from the broader sector that isn't necessarily captured in this report.
Thank you. I would agree with you. I think that the template's very narrow. That doesn't help, doesn't give the full picture. I think there is much more we should be doing in terms of how all of the different partners and organisations come together and support in this space beyond just those beyond services that are commissioned, because actually, as you've rightly said, there's lots of people doing lots of work here and communities do lots of work, and it's how we pull that together and describe it in a better way, I think, because we tend to focus on either the statutory services or the services that we commission. Actually, there's a much broader remit of organisations that we need to recognise and harness, frankly, and also there will be organisations which you wouldn't immediately think could support in this area that we also need to work with. So I take on board. I think it's something that we need to be much better at doing. Thank you.
Just add to that, not regarding the Better Care Fund, but when we were setting up the rough sleeper accommodation, and we obviously went to a number of voluntary organisations to support us on that occasion, and following the setting up of that, I wrote to each of those organisations thanking them for their contribution, and a lot of responses that I got back was, we were really pleased to do this and we would really like the opportunity to be asked more often. And I fed that back to Hilary and said, you know, we sort of we tend to go to the ones we always go to, and we don't think about the others that we did on that occasion, but we hadn't perhaps in the past, and they were really keen to help us. So I think you're absolutely right. There is scope out there within the voluntary sector with work that they're already doing, but work that they're prepared to do that we just don't pick up on, and we need to do that. So thank you for raising that. And you can put that in as a recommendation as well. What recommendations have we got, Henry?
So I've noted down that a interventions dashboard to be brought back to the board as an item with a focus on health inequalities as proposed by David.
Yeah, I'm not quite sure it's an interventions dashboard. I think it's a broader set of metrics on top of the nationally required ones, and I think those will be defined by the working group that's working on it, and they'll bring back their recommendations for how which metrics we use to make sure we're getting good outcomes and good value for money.
Thank you. That's great.
And was there anything else?
No, that was it.
Anybody else note any other recommendations that were there? Right. Then that's a recommendation. All those in favour of that recommendation along with the report, thank you. Anybody against? Any abstentions? That's it. So we now move on to item 10, which is the most appropriate agency. And Sue Harris, Director of Strategy and Partnerships of Herefordshire Worcester Health and Care Trust, representing the Trust remotely, will present the report. Thank you, Sue.
Yeah, no problem. And I will invite Helen in as well afterwards, if that's okay.
Yeah,
obviously
fine.
Provide the police perspective. It's a very short paper, but I know that this was discussed some months ago by the board. So it was really just to give you some assurance on how actually some of this is translating and in delivery of frontline services and some of the learning that we've undertaken together. So what the paper covers is the fact that we've got in Herefordshire the inter-agency monitoring group, and that brings colleagues together, and it's a really great opportunity then to look at the MAA impact and actually use case studies to explore whether we think there are gaps, what we could be doing differently, are protocols being followed, etc. So it's very well attended and always is, and you will see it's a broader meeting than just the Health and Care Trust and the police. It's got the ambulance service, learning and development reps and mind. So bringing together that whole piece around the way in which we are delivering mental health care across the county. So from an NHS point of view, this is not a policy that is causing us huge amounts of concern. We have now found ways where if it's actually in real time, so out there on the front line, if there is a concern either way, that the organisation does need to call out the police, we have escalation points and it is enacted very quickly, and then we've got the appropriate response most of the time. And then we reflect on those particular issues as they occur to think, do we need to change any of our processes and structures? So for two organisations, I think this is working well. Operational colleagues say that we're still learning and testing, and Helen, your views on that would be appreciated. But you'll see as well, as actually was a review last week. Obviously that's too early for us to have brought anything concrete through to the board this time, but I would expect the findings to come through and provide that assurance that I've obviously wanted to give you verbally. And I think for most of us, I think it is about learning when we are increasing and escalating risks, that we're doing that in the most appropriate way. And actually, I think we have examples where historically we have done that in the NHS, when actually there probably should have been an NHS response earlier, or we should have done more before ringing the police. So I think and obviously the police have reflected the same way back, that they've often gone out to things that really they're not well placed to respond to either. So we're getting under the bonnet of it. We've got real-time monitoring and risk management, and then we've got the review that will formally look across all of the pathways, because this isn't just mental health, it could be any mental health presentation. So equally out there with adult social care and Why Valley Trust for A&E, for example. So Helen, I didn't know if you wanted to come in.
Yeah, thanks, Sue. To be honest, that's a really comprehensive update of where we are. There's not a huge amount that I can add. Just so that for everybody's aware, Most Appropriate Agency was implemented by West Mercia in April of last year, following a successful implementation of a similar model in Humberside. And in very brief summary, it is all about the police not deploying to incidents where we have no statutory duty. So it doesn't just include mental health related stuff. It includes things like I don't know, road closures for potholes, so it's a really broad policy. Subsequent to that, obviously the national right care, right person policy has come in, and effectively that underpins all of the approaches that we're seeking to take through Most Appropriate Agency. Like Sue said, we've got an escalation process in place. All of the people across the relevant agencies locally were briefed, quite some time ago now, in relation to the implementation in the early stages, and we've worked through improving the way that we work together through that escalation. Sue's right, there's been learning on both sides. That makes it sound adversarial, doesn't it? But there's been learning by all agencies involved. There will no doubt continue to be learning, but from my perspective, that review and escalation process works effectively. The reviewers were in last week. That review is being led from the police perspective by my colleague and Detective Superintendent Leanne Lowe. I don't know what the timescales are for the conclusion of that review, but if there's a requirement to come back and brief Health and Wellbeing Board once we have that information, then either she or I will be happy to do so.
Any questions? No? Well, thank you very much, both of you, for the update, and we look forward to the results of the review. Therefore, basically, we are noting the update and just voting that we support, that we note the update. All those in favour? That's it. Thank you very much. Thank you. We now move on to any other business, and we've got two items. The first one is from Harpal, which is a verbal update on oral health, which we've covered really inadvertently earlier on, but that doesn't stop you, Harpal, from having your say on the matter. Thank you.
Thank you, Chair. I think that there's not a whole lot I want to add on top of the notes that have been shared. One was a reply to the relationship between oral health and childhood obesity. That was brought up at board about 2 boards ago. The report there kind of shares there is an association between oral health and childhood obesity, but the causation data isn't quite there at the moment. There is stronger evidence between adult obesity and poor oral health, but childhood obesity, the data is not quite there at the moment, but there is some form of association found with the literature. And that's, shall I pause there before I go into the second bit?
Okay, anybody want to ask any questions up to now? No? Okay, carry on, Harpal.
And the second question that was, I think, asked by yourself, Chair, was around fluoride varnishing and whether that's offered by dental practices. And I took this back to the Oral Health Improvement Board, we had a lengthy discussion around fluoride varnishing. So for those that aren't aware, fluoride varnish can be applied to both baby teeth and adult teeth by dentists. The process involves the varnish having quite high levels of fluoride on the surface, and that can be put on teeth twice a year, and that prevents decay. And the recommendation is, at the moment, it's quite strongly recommended for children and adults who are at higher risk of tooth decay. And in Herefordshire, we've asked, when asked the local oral health improvement board, it was recognised that more can be done to publicise fluoride varnishing. And at the moment, we're a little bit unaware of how much fluoride varnishing is being offered. So one of the actions that was taken from the board is to start looking at that data. And that data is supplied by the NHS Business Services Authority, BSA. And at the next Oral Health Improvement Board, we're going to see how many dental practices are essentially claiming for that service, so we can see how many fluoride varnishing services have been applied in Herefordshire. And from there, that will feed into part of the plan on how we can publicise this a bit more across the county.
Right, thank you. Anybody got any questions? Right, we now then move on to Kristen to give us an update on childhood obesity, which to a degree we've also covered at the wrong place.
Thank you. So there's a short couple of slides attached to this agenda item. So this is in response to a question raised at a previous board meeting. I'll just run over a couple of points. So the latest data for 2022-23 indicates that in Herefordshire, 19% of children in reception were overweight or obese, rising to 35% in year 6. And we can see there's a long-standing pattern of obesity doubling during primary school, as indicated there. Slide 3 just shows the impacts of deprivation on weight, whilst there's little correlation in year 6 in our local data. There's a more noticeable link with the year 6 data, and that's in line with the national trend. And slide 5, the Herefordshire proportion of overweight and very overweight or obese children has followed the English trend, with a peak seen in 2021 data and then a slight downward trend in the last year's data. Happy to take any questions.
I've just got one question, which is probably very parochial, really, because it's my ward, or part of it is my ward. On your slide, which shows 18 reception age children measures being percentage of reception class children who are overweight or very overweight, Mortimer ward, which is up in the top left-hand corner, is showing, I think, at 23.3 to 34.8%. But then when you get to year 6, it's down, it's at the bottom. So is that saying that suddenly from reception they go from being very overweight to year 6 they become below right at the very bottom of being being overweight?
No, what it is saying is that a higher proportion of reception year children are overweight and very overweight in that area. Yes. But in year 6, there's a lower percentage.
So they suddenly become thinner?
No, there are...
Same time. It's the same time period, isn't it? It's all in the same year.
Same year. It's very odd, isn't it? I looked at the others, and well, actually, there's a couple that Bromyard is also changed, but most of the others are fairly very much the same. Oh no, they're not actually.
They are all quite changeable.
They are changeable, aren't they? Right, I've got to get on to my people in Mortimer Ward with overweight reception class children.
Particularly with our data in Herefordshire, it is quite changeable. You'll notice looking at maps like that. Yeah, they are very changeable.
And you see, the other thing about it is that Mortimer Ward is not a particularly deprived area either.
No. But if you look at slide 7, so that's our 3 years pooled data, you will notice that some of our more deprived areas are highlighted there in both maps.
Yeah.
Can I come in here, Chair?
Yes.
Yeah, I mean, with Herefordshire, we're talking quite small numbers, so there's
Yeah.
a lot of variability.
Yeah.
So that's the only thing. I think the key message is that we have
5.
quite a significant proportion of
Yeah.
children who are overweight and very overweight. I don't always like to use the word obese because it creates stigma.
Yeah.
I thought the slide on deprivation is quite worrying when actually 1 in 2 children at year 6 in our most deprived wards are overweight or very overweight, compared to
Yeah.
1 in 4 in the most affluent wards. So I think
Yeah.
that is quite worrying. On a positive, and I've published research in this area, we know that actually about 16% of children who are obese at reception year actually go to a healthy weight at year 6.
Yeah.
So change is possible,
Yeah.
only for a small minority of children,
Yeah.
but there are some opportunities there. So some real challenges, but some already fantastic work going on across the county, I think. And obviously this data it's a real world-class database
Yeah.
in terms of how we can kind of target our support.
Yeah.
Talking about healthy schools earlier, let's try and focus on those areas where we know there might be some
Yeah.
potential challenges.
Yeah.
So
Yeah.
just some observations.
Yeah. Yeah, the numbers are small, so it. David. Oh, sorry. Jane.
I'm happy to go after
Jane.
Jane, but yeah, I mean, Matt, I was looking at that same chart, the 51% down to 26%, and the fact there's very, very little difference at reception class. Do we know why that difference is? Is there any evidence out there that says what might explain that position, and therefore what we could do about it between the ages of kind of 5 years old and the end of primary school?
Not that I'm aware of. What in terms of the gaps between affluency and deprivation at reception?
Yeah,
compared
so
to
why
year
it's pretty
6?
flat. So they get to school,
Yeah.
and there's no significant variation by deprivation decile. But when they leave school, it's doubled almost. I'm just trying to understand.
Yeah, I don't know. Obviously, as children get a little bit older, there's more autonomy in their food choices, and whether families, with less income, I don't know, it might be more staple diets between the ages of kind of 0 to 5, but between 6 to 11, children become a bit more demanding and peer pressure and all kind of stuff. It's not, I don't have a straight answer, being quite honest, but I think it is complicated. But yeah, that's something we could look into. Unless anyone else has any ideas.
No, because it is complicated. Because I say my ward is not an area of deprivation, and yet at reception years they are overweight, and then by year 6 they are not, and then conversely you've got a section of Bromyard which again I wouldn't have said was a significant area of deprivation, where they are not particularly overweight when they enter reception, but they are more overweight at year 6. So it's the other way around, and I mean, there are certain areas where it doesn't matter which age you look at, there's a problem, but there are certain anomalies in other parts of the county, and I wonder whether in some of the more rural parts of the county, which is where I represent, whether part of it is the rurality of it, and the fact that the farming community tend to be a sort of they're hearty eaters. I mean, they are. They are hearty eaters.
I mean, what I was thinking is it raises the question about whether there is an issue about independent access to unhealthy foods for children of a certain age.
Yeah.
Is it easier in some parts of the county to access unhealthy, fast food, processed food, than in other parts of the county, and therefore whether that affects it. But I'm still, I guess, the issue about just taking deprivation in isolation is that IMD 1 and 2 can be dotted around all over the county, can't they? They're not necessarily all focused in one area. So it's you're right. I mean, it's more complicated. We're not going to solve it this afternoon, are we? But
I think there's 150 determinants of obesity. It's a complex issue. So kind of saying it's one of those 150 that calls into that is really difficult. That's not to say it's insurmountable, but I guess it's maybe there is something about some insight work in some of these areas to really understand the challenges. Are there themes coming out in some areas compared to other parts of the county? That could be a piece of work.
I mean, if you look at the, I mean, my husband and I were having a discussion about this when we were on our holidays. If you look at the market towns and the cities across the country, if you want to have a takeaway at 11 o'clock at night or whatever, you don't even have to get out of your house and drive your car or walk to the takeaway. You can just pick up the phone and it's delivered to you. So it's even less exercise now than there was when you had to actually go to the takeaway to actually buy your food and stand and wait for it to be cooked. Whereas in the rural areas of Herefordshire, that facility is not available. It just isn't available. So that is an instance where certainly market towns and the city, there will be much greater access to fast food at any hour of the day than there is in the rural areas. Jane.
In terms of uptake of the opportunity to be weighed at school, is there any difference by area of the numbers who are refusing? I don't know, I'm looking at actually the numbers who are refusing to be weighed. I understand that's an increasing problem, but I don't know.
I think we're really lucky locally. Our uptake has been really high for quite a number of years. Even during the COVID period where we were only required to measure a really low number, I think it was 25%, we managed 75%. So our uptake figures are really good. It's usually around 98%.
Super, that's really good. So we've got the right measure, and equally, I was just fascinated by this slide on that at reception there's no difference between deprivation, and then you say 5 years later, there really is. I mean that just, I think you said, Matt, we need to do some more work around that, because we must be able to do something in those, in 1 and 2 to make that look more like 4 and 5. If we can understand what the drivers are about why it's so different, then
I mean, there's so much research being done on there, and everyone's struggling with the whole problem. This isn't just isolated to Herefordshire. That's not to say we can't do anything about it. I think the evidence now is whole system approaches. It's kind of multiple different things focusing on overweight and obesity, but it's trying to focus on what are those key things we want to focus on. So that's something we really need to work together as a board if that's something we're really concerned about. We've got 0 to 5s as our, one of our priorities. That's probably where we should focus our attention in the first instance, but that's not to say lots of other things we can't do. And also there's bigger things, wider partners, transport, infrastructure, economy, schools, all these kind of opportunities can help with this. It's how we kind of leverage that support, I think.
Anybody else got any questions?
Yes. Just to mention the Healthy Tots programme, which is aimed at our early years nurseries. When we think that 98% of our 3 and 4 year olds are accessing the 15 hours free childcare, the universal 15 hours free childcare in nurseries, the Healthy Tots programme is a real opportunity where we can dictate the criteria within the framework. So we can, for a nursery who's going to sign up and work through that framework, we're in a position where we can really steer their healthy eating policies. There's no guidance in early years nurseries around food. There is in schools, there isn't in nurseries. So we can really kind of, don't like to use the word dictate because you want to bring people along with you, but I think we're in a position where we can really influence the menus in nurseries, just saying that they don't have squash or, they don't have biscuits at break time, and they limit, birthday cakes and things like that people bring in for children. by being part of the programme, we can really support the nurseries, because that's one thing that we do hear a lot from nurseries, is that, you know, they don't have control over what the children bring in their lunchbox. They might have a policy, but the parents obviously don't always listen to it or stick to it, or they do their own thing, and often that involves crisps and chocolate bars and fizzy drinks and all sorts of things. So there's a real hope that by implementing the Healthy Tots programme and working with those settings, we can really drive best practice and eradicate, in some cases, fizzy drinks and squashes and chocolate bars and whatever in those establishments. And, you know, and a large proportion of our 3 and 4-year-olds are accessing those provisions. That's all, thank you.
Anybody else? Steve?
Probably worth a discussion outside the meeting, but we're piloting something in Worcestershire called Off to an Active Start. Happy to have a conversation with you about what that actually is, that ties in with that. Sorry, just taking the VCS hat off and put my day job hat on for a second.
Absolutely fine, fine. Hilary, did you want to say something? No? No? Right. Anybody else? No. Okay. So we moved into the, we can't vote on this because it's under any other business, so we just note the reports. Okay. And then we then move to the work programme. So we've got the work programme in front of us. The June one is pretty full. In fact, it's very full. Do we think all of these items are going to actually come to the June programme?
It's hard to say because some papers and some reports have to be deferred for their particular reasons. Some are withdrawn naturally, but yes, June is looking pretty full.
Yeah.
Can I say, Chad, I don't think the child death overview panel report is going to be coming anymore. I think that's going to be going to the safeguarding board. I think that's been agreed now if we're all comfortable with that. So that would take one off.
I know the autism strategy is coming. So it is a fairly full. It is a fairly full meeting. So perhaps we could make a plea that the reports are as concise as possible. That's all we can do, really. If we move back to the 3rd of May, private development session, we had a number of suggestions, haven't we?
Yeah, it's just worth noting on that second page, there are potential ideas for the development sessions that are listed there, and so it was brought to this board meeting for the members to consider.
So does anybody have a burning desire for any one of those items to be considered first?
When would the JSNA be?
Yeah, I don't think that's going to be ready towards the end of this year, so I think we'll probably have to rule that one out for the next one, but we could do that in the future.
Local plan won't. Yes?
Prevention has come up a lot, not just this meeting, but previous meetings, so perhaps a focus on prevention. And I appreciate that's a broad brush.
That sounds fine. That sounds fine. Christine?
I don't disagree, but I was thinking that would make sense alongside the community paradigm, and I would have preferred that to come slightly later when we've got the programme manager for the paradigm in place.
Right.
But happy to take them separately if you think that would be better.
David?
There's a third complication I'd like to introduce into this thought process as well, is that often, whilst they're not directly aligned, there's quite a strong link between prevention and health inequalities, in that if we focus our prevention in the right way, it has a big impact on health inequalities. So having them as separate items might be a more complex one. So maybe if it was kind of community paradigm prevention and health inequalities as a themed intervention, themed approach, then that might make sense. But not on the 3rd of May.
No. Does anybody have any?
It sounds like a number of those things need to come a little bit later. I mean, it depends on availability of staff, but people understanding SHIMI, that standardised hospital mortality indices, and some of the other mortality indices. I think that data's already there and available, and we work on it. So if Chizo and Chris Beaumont and others are available, then we could certainly do that and just give people a broader understanding.
That would be that. Perhaps we could be the first one as a start and see how we go from there. Yeah, I've also had an email from the Food Alliance, which Matt and I have discussed about, and I don't know whether you want to at some stage squeeze them into the Health and Wellbeing Board meetings, or whether we would put them into one of these workshop sessions.
Yeah, I'm just trying to catch up now. So are we suggesting mortality for the development session? We've done some work on excess mortality we could bring in terms of what that data is telling us. It needs a bit more work, but I think we'll probably be ready by May. Is that what we're suggesting? Are we saying that ahead of prevention and community paradigm?
Yeah, because
that comes
Christine.
later.
Yours needs to be a bit later.
Yeah.
Christine?
Just a question. What is Herefordshire local plan? Is that the county plan, or are they different plans?
No, that's what would be the plan for development across Herefordshire going forward to 2041, which
Right.
will replace the
So
present.
the daddy of all plans.
Yeah, and I don't think that's not going to be ready to be considered for May the 3rd. Yeah, it's the daddy of all plans.
Does that fit with the wider determinants piece? Do they fit together?
With the
wider determinants?
Yeah, just on that point, it might be worth just revisiting the timescale for the local plans. I think the board would probably want engagement throughout the development of the local plan would be my advice, so we can actually influence what goes in it from a health perspective. So we'll find out what that date is. Christine, I didn't answer your point, Chair, about the Food Alliance, so I'll leave it up to the board. That was previously a priority for the board, food and sustainable food. But whether the board feel they want to spend a session on that, whether at the board or development, I'll leave that up to others.
Well, if we start off with the mortality one, which is, 'cause that's the first one we've sort of trialled, if you like, see how that one goes, and then we look at that one or the next meeting to see what then has come forward, because the local plan probably will have been a lot further forward by then.
What we're saying around prevention and community paradigm, we'd like later this year.
Yeah.
Yeah.
Yeah. Okay, David.
Can I just check, we're talking about Friday, the afternoon of Friday the 3rd of May for development session?
That's the date that's been suggested, yes. There has been some queries about that as to whether that's too close to the bank holiday.
Because it is the beginning of a bank holiday weekend. I was thinking more just Friday afternoons are not the best time for development sessions from my experience, if it's involving a...
Yeah, so in terms of finding people's availability, Friday the 3rd of May was the best date for the vast majority of people. Any earlier than that, and it was starting to be quite hairy. I can revisit the dates, but Friday the 3rd was the soonest date that worked for the vast majority of people, so...
They aren't all on a Friday, are they?
Well, no, I don't think they are. I'll have to check, but I don't think they are.
I don't think they are.
No, I was aiming for dates that were most beneficial for most people. Accepting, of course, people's availability close to the time may be not there.
Yeah, I think the issue that was raised regarding the 3rd of May was the fact that it was near the bank holiday, and that some people might be going away because of the bank holiday. I don't think at the time anybody raised it as an issue because it was a Friday. The July one is the July one is a Wednesday. Yeah, they're all different days. So I think it's just unfortunate that that was the only date really in May that we could do.
It's always tricky, isn't it? I've just had a look actually, but it was it
Yeah.
was okay, but it's not now.
Yeah, that was the problem with scheduling these development sessions. It was difficult to pinpoint dates where it was, you know, the best outcome for everyone. But again, I can repeat, I can look through the dates again, and you know, we could issue a poll, like a doodle poll, for April. Well, ideally May.
May.
And see what the best possible
Yeah.
date is.
Okay.
Yeah.
Let's do that then.
Okay.
Yeah. Okay. Right. So that's it then. So the date of the next meeting is the 10th of June. I formally close the meeting.